Good morning, everyone. Myself, Ansa from the Department of Respiratory Medicine. Today's case presentation, commonly uncommon. So, 60-year-old male, non-smoker, government employee, presented with complaints of breathlessness on exertion, which was progressive in nature for the last 9 months. No history of cough, hemoptysis, chest pain, connective tissue disorder symptoms, fever, and any other constitutional symptoms. So past medical history wise, he's a non-case of CML since 2010, and he was started on imatinib and switched over to bosutinib in 2012 due to intolerance. He was on bosutinib for the since 2012 until 10 days of presentation. No other significant medical or family history. Evaluation, and he was initially evaluated at his local place, and he was diagnosed to have right-sided pleural effusion in September 2023, and they have done a diagnostic and also therapeutic aspiration. Almost 3 liters of fluid was taken, and the analysis was lymphocytic exudative in nature, and smear culture, everything was negative. Since the effusion has come lymphocytic exudative in nature, and the expert is negative, cytology, everything is negative. They have he underwent medical thoracoscopy on 20th of October 2023, and there also the biopsy, culture, expert, everything came negative. Then in Jan 2024, again he started to have breathlessness. So on evaluation, he had again recurrent right-sided pleural effusion. Due to that, he again underwent repeat medical thoracoscopy on 25th of January 2024, and that pleural biopsy has come as suggestive of malignant mesothelioma. So after that, he has underwent the tetracycline fluorodesis on 5th of February 2024. Talc was awarded because he was telling some allergic reactions before that. Coming to the examination part, general examination, it was unremarkable. Systemic examination, there was reduced breath sounds in the more on the right side, and right in infrascapular and interscapular area, absent breath sounds were there. It was consistent with the bilateral pleural effusion, more on the right side compared to the left side. Rest all the systemic examination were normal, and so this case is a right side bilateral pleural effusion, more on the right side. So we have done an ultrasound screening. Followed by that, we attempted diagnostic tapping. So that analysis has come as lymphocytic exudative in nature, and we have sent the routine microbiological test, AFB, expert, MGIT, everything has come negative, and cytology also has come negative. So everything is negative. So we have to go to the next step for diagnosis. So the patient has underwent medical thoracoscopy. So this was the medical thoracoscopy picture. It was essentially a normal visceral parietal diaphragmatic pleura, except for in the down fifth image, you can see some few discrete nodules. Other than that, everything was normal. So this was the chest X-ray pre-thoracoscopy. First one, you can see bilateral effusion more on the right side. And the second image, you can see the post-thoracoscopy image. The right side, you can see the ICD, and the right lung has expanded also. Left side, effusion is there. So the thoracoscopy picture, everything was also, it was almost normal. So we have done a CT thorax also to rule out any other causes there for pleural effusion. That has also come as no other significant abnormality except for the effusion. And the pleural biopsy has come as a foreign body granulomata, consisting of mainly containing the crystalline foreign material and focal lymphoid aggregates, and that we are considering because he has undergone a talc fluorodesis before. That might be a reaction to a foreign body itself. So all the workup has come now inconclusive. So we have to find out next what is the diagnosis of the patient. Then after ruling out everything, we have come to a diagnosis of a drug-induced pleural effusion. He was on bosutinib since 2012. So a final diagnosis was made. And for that, we have de-challenged the patient with bosutinib. And patient was also given steroids for 2 weeks for reducing the inflammation, everything. And we have called the patient for a review. So after that, the patient has improved clinically and we discharged the patient with advice for early follow-up. So bosutinib was replaced with nilotinib for CML. So we can see a follow-up X-ray. First one is a 6 weeks follow-up X-ray, and the second one is a 6 months follow-up X-ray. We can see like effusion has come down and lung is fully effusion has come down. So just giving few points about drug-induced pleural disease. Drug-induced pleural disease is uncommon in contrast to drug-induced the parenchymal lung disease. So pleural fluid eosinophilia, clinical clue to the presence of drug-induced pleural disease, even if it is a non-specific finding. It can present as mainly the pleural conditions. Drug-induced can present as pleural effusion, pleural thickening, pleuritic chest pain, and it can also occur in absence of parenchymal involvement also. The clinician should be cognizant of the possibility of a drug-induced pleural reaction. So these are the main drugs causing pleural effusion: amiodarone, beta blockers, hydralazine, then chemotherapeutic agents wise methotrexate, cyclophosphamide, erlotinib, then ergot derivatives, biological agents also, interleukin 2, 11, TKIs, then immunoglobulins, then some miscellaneous agents, valproic acid, nitrofurantoin, dantrolene, procainamide, sirolimus, d-penicillamine, acyclovir. So coming to the mechanisms causing the pleural effusion. First one, it can be a hypersensitivity or an allergic reaction. Then some drugs can cause a direct toxic effect to the pleura, producing some free radical effect and all. Then suppression of the antioxidant defenses. And also some drugs can also cause chemical-induced inflammation. So in this case, it is mainly the culprit is TKI. So the tyrosine kinase inhibitor that target the BCR-ABL fusion oncoprotein is a standard treatment of Philadelphia chromosome positive CML. So reported pulmonary complication for that is pleural effusion, then pulmonary artery hypertension, ILD also. So coming to the incidence of the pleural effusion for TKIs has been reported as maximum for dasatinib, that is 30%. Then bosutinib, it is 1 to 10%, and other drugs causing is imatinib, nilotinib and all, that is like less than 1% only. Systematic analysis of pleural fluid in conjunction with the patient's clinical presentation should allow the clinician to arrive at a correct diagnosis in approximately 90% of cases. And awareness, some pharmaceutical agents can cause pleural effusion may help the clinician recognize the pathogenesis of some effusion whose cause is less obvious. This may obviate the need for unnecessary and possibly harmful invasive procedure. So my case was a drug-induced pleural effusion. We have worked up everything and all the tests, everything was negative. So we came to a diagnosis like drug-induced pleural effusion, that is the TKIs.
Is it common after 13 years of being on a drug to cause pleural effusion?
Yes.
So from 2012, the patient has been on this drug, but now you made a diagnosis of exclusion based on that drug for 13 years?
Yes, sir. It depends on different condition, like different drugs. It can come.
This drug?
For this drug also, it can mainly 10 years that it can take.
Because it's for almost effusion. 13 years of starting the drug, you're diagnosing effusion as drug-induced complication. Is that described?
That is not described anywhere. Years can vary. That they have described in other articles also.
Time for questions.
I just have a question. Any risk factors for developing this? Are there any? How do we think about this? One is you have to rule out. That means extensive testing is to be done. So are there any things we can look for as risk factors for people who are...
Risk factor wise, nothing is there. Mainly the diagnosis of exclusion only we will come to this diagnosis.
Okay. Yeah, please.
So the drug includes especially TKI induced pleural effusions. Reports are very, very less. So we really don't have a big data to suggest what would be the risk factor. Then again, sir, the same thing, 10 years duration, even we are surprised, but that is how it is. And there is no mention whether it is dose dependent or time dependent. So none of those data is available at the moment. So in this patient specifically, we also went ahead and do a thoracoscopy. And we can question why you went ahead and twice it was kind of inconclusive. Because second time when they have done a thoracoscopy, there was a differential of malignancy. So just to rule out that we went ahead. Otherwise, we would have avoided to do it and probably stop was there and make sure that.
Yeah, medicine one is there. Anybody? So you have only 7 minutes to complete your presentation.